Professor Chapman, we are live on Facebook.
Excellent. Great. Hi, everybody. Welcome to this Facebook from IVF Australia. And what we're going to do tonight is run through what an IVF cycle involves. So we've already had a pile of questions, so we'll get to those once I've done the talk. But for many of you, I suspect, have already been through an IVF cycle or are contemplating one in the near future, or are worrying that they might need one in the future. But anyway, I hope I can ease your concerns and give you an overview of what's going on. So who am I? Well, I'm not Dr. Rabia Sheikh, who was supposed to be doing this. Unfortunately, she's busy tonight delivering a baby, and that obviously comes first. So who am I? I'm a professor of obstetrics and gynecology at the University of New South Wales, and I'm a senior fertility specialist with IVF Australia. In fact, I was one of the founders. I've been doing IVF for 35 years. So I've seen lots of babies grow up to be adults and beyond during my time as a fertility specialist. So in fact, today I'm probably one of the most senior, that means oldest, but therefore most experienced IVF doctors in Australia. So one of the things I do, and I think it's very important, is to give you guys as much education as possible. So in addition to this live broadcast, I also do a podcast. You might be able to find this. It's called The IVF Journey, and it's on iTunes. And every week I do a little segment that you might be interested in looking at. It covers a whole range of things, which includes what I'm going to talk about tonight. So what does an IVF cycle involve? Well, today with the current technology, what we aim to do is produce a good number of eggs. That by good, I mean something between 8 and 15 is ideal. And with those eggs, we can create somewhere between 1 and 5 embryos would be the range that 90% of couples would get once they get a good number of eggs. It is a numbers game, and if you get low numbers of eggs, your chances of success are lower. So the first step in an IVF cycle is to override the natural processes within the ovary. So each month you will be making 1 egg. That's what nature has sorted out. That's probably to stop us having multiple pregnancies, because we're not rabbits or mice. That process is overridden by giving you an extra dose of the hormones that your brain normally does give to your ovaries to produce that 1 egg. People worry about that stimulation, producing lots of eggs, will bring a menopause on earlier. That's actually not true, because in that process of nature producing only 1 egg, some 100 to 200 other eggs are actually lost every month. And that's why women eventually go through the menopause, because over that 50 years of the ovary on a monthly basis losing 100 eggs, they run out of eggs. The ovaries run out of eggs. So what we're doing in IVF is actually saving many of the eggs that would otherwise have been lost. So it makes no impact on your long-term age of menopause. So we stimulate with hormone injections. Generally, that's a once-a-day injection starting just after your period, and usually goes on, the average is around 11 days of injections. During that time, we want to know that your ovaries are responding in an appropriate manner and looking at them heading towards being mature. Now, to do that, what we need to do is blood tests to measure your hormone levels, because as the follicles which hold the eggs grow, they produce estrogen, and we can measure those levels of estrogen in the blood. So watching those estrogen levels going up tells us that things are happening, the right things are happening. Then, in parallel with that, we also do ultrasound scans. So that means having what's called a transvaginal scan. Many of you already have had that as part of your investigations, where we can look inside from the vaginal wall. The ovaries are very close to the vaginal wall, and we can see and count and measure the follicles that are growing. We generally do that 2 or 3 times in that stimulation 11 or 12 days. That means coming to the clinic for that. Injections, we teach you how to do them at home, or maybe your partner does them at home if you're scared of injections. So what we do is watch those follicles grow, and when they get to the right size and the hormone levels are appropriate, we can then go and collect the eggs. So collecting the eggs, again, is using vaginal ultrasound to guide us, to guide a needle through the vaginal wall into the ovary, and we suck out the fluid in each of the follicles. And in those follicles, about 80% of them will have an egg. Not all of them, but about 80%. Doing that procedure can be done under a light sedation, where you're virtually awake, or under a full general anesthetic. Patients vary in their desire to avoid pain or to be awake. So we customize that to what you want. In the operating theatre, where we're doing the egg collections, the scientist will be standing there with a microscope. And as we suck the fluid out of the follicles, they're looking under the microscope to find those little eggs. Once those eggs have been found, your partner or donor will have, the sperm sample that they produce will be put with the eggs that afternoon. The scientist will usually ring you the next morning and tell you how many of your eggs fertilized. So what we expect is around a 60 to 70% fertilization rate. Not all eggs are good eggs. So if you started with 10 eggs, you could expect that 6 or 7 of them are going to fertilize. By the time we grow them on to 5 days, which 85 or 90% of clinics in Australia do grow them on to day 5, because when we go to day 5 embryo, we know it's got a much higher chance of success than a day 2 embryo. So in the laboratory, with the conditions that we have now, which mimic very closely what would be happening in your fallopian tube, we can grow the embryos to a stage where they're just before they would normally attach to the womb. So on the 5th day, we will be putting one embryo back into your uterus. We choose one embryo because the risk of twins is clear. If you have a twin pregnancy, you have twice the risk of losing that baby compared with a singleton baby. And probably more important to us all is that cerebral palsy is 4 times more common. So why would you put more than one embryo back? And we can say that because once we get to that day 5 and we've got more than one embryo, we can freeze it. And again, the last 5 years have seen the freezing processes occur with such great technological advance that frozen embryos have the same chance of success as a fresh one. So we're not losing anything by freezing them. The transfer is usually done just in the next door to the laboratory, almost like a pap smear. Slightly uncomfortable, obviously. All women will know about pap smears and how uncomfortable they are, but it's no more uncomfortable than that. The embryo is placed inside the uterus, and we will wait for another 10 days to do your pregnancy test. So the total package from beginning the stimulation injections to a pregnancy test is like a normal 28-day menstrual cycle. The extra medication that you'll take, in addition to the stimulation hormones in the beginning of the cycle, will be the support that we give to the lining of the womb in the second half of the cycle. This will predominantly be progesterone pessaries or tablets given into the vagina that you'll do twice a day or 3 times a day, or using injections of pregnancy hormones, which make the ovaries produce more of the hormone progesterone. Because progesterone is the most important thing in the second half of the cycle. If we get falling levels of progesterone, the lining of the womb will break down too early and you won't get pregnant. So we have to give you that luteal phase support. So that's what a cycle is, from the start to the finish. So I'll see whether we've got any questions that Kelly would like to give to me, because I know we've had some already.
Yes, actually, we do have a question here, Professor Chapman, about how can we fix the quality of the egg? Certain diet, perhaps.
There is no evidence that diets make any difference to egg quality. There are many things written on Google, but none of them have any scientific basis. I know that there has been some work, I know, published this week out of Adelaide with mice, suggesting that a Mediterranean diet, that's lots of good olive oil, some nice red wine, and lots of green vegetables, improves the quality of eggs in mice. But no one's shown that in humans, and I don't think the fertility rate in Italy is any better than in Australia. So I'm not convinced. The only dietary advice is for women who are either overweight or underweight. Both of those can affect egg quality. So in terms of diet, I don't have any miracle suggestions that's going to improve things. Unfortunately, egg quality, so far, we have not been able to change. And while I talked about the loss of eggs over time towards the menopause, in addition to the reduction in the number of eggs once you get over 38 to 40, that continuing decline can impact on your chances of fertility in an IVF cycle. The other problem is that quality also declines. And so far, we've been able to find nothing that reverses that quality.
There's another question here from Steph. What are the chances of pregnancy with an AMH of 1.5? I'm 28 years old with an AMH of 1.5.
So 1.5 is low, but it still says there are eggs there. So when I stimulate you, I would be hoping that we would get somewhere between 3 and 5 eggs rather than the 8 to 15 that I was talking about as being optimal. So what that means is that when you have a 70% fertilization rate and 1 in 3 of those fertilized eggs will get to a blastocyst, if you start with 5 eggs, your odds to get a good embryo are lower. So therefore, that does lower your chances of a pregnancy. 38 years of age, the egg quality is only just a little bit worse than when you were 30. That's not a big problem. It's the egg numbers that are the issue. And you may need to go through 2 or 3 cycles to get produce enough embryos to give you a good chance of pregnancy. If you were sitting across from me in the desk, I would be giving you, in a single IVF cycle, I'd be giving you a 30% chance of a pregnancy from 1 embryo transfer. The problem is, if they're only got 2 or 3 eggs, and when we go to collect them, you may not get an embryo. So while 30% sounds reasonable, unfortunately, there may be cycles where you don't get an embryo transfer. So that would overall reduce your chances of success.
Professor Chapman, we also have a question from Ali here. What are your thoughts on acupuncture and IVF?
Well, I'm an author of probably the biggest randomized controlled trial ever done on acupuncture and IVF. We published in the Journal of the American Medical Association about 4 years ago, over 1,000 patients, and it doesn't work. So based on science, I do not prescribe it for my patients. However, there are a lot of acupuncturists who make great claims about it, but the evidence is not there. There are now more than 20 studies, randomized studies on acupuncture, and there might be one or two that suggest there might be a benefit in pregnancy outcome. What I can't deny, but it doesn't change pregnancy outcome. I think acupuncture is nice in the sense of producing relaxation. And IVF is a very stressful process. We call it the IVF roller coaster in terms of emotions. So you come into an IVF cycle believing you're going to be the one that gets pregnant. We give you the medication. Your ovaries grow, the follicles grow. We get excited. We're going to be successful. We then get to the egg collection and we get eggs. And you go home from the egg collection knowing that you're going to get pregnant. So you're right at the top of the peak of a roller coaster. The next day, the scientists ring you and tells you that only 6 of the 10 eggs are fertilized. And that's a bit of a hit in the head. Even though I told you before that's what's going to happen, it's still a hit because you wanted 10 out of 10 to be fertilized. And then when we get to day 5 and we've only got 2 embryos, that can feel very disappointing, but you only need 1 to get a pregnancy. So it's still good. And then there is this horrible period of time between the transfer of the embryo and a positive pregnancy test. Well, am I pregnant? Am I not? Am I pregnant? Am I not? And that's, patients tell me, is the worst time of the whole cycle. And then you get a blood test. And then me or the nurse rings you and says, I'm sorry, you're not pregnant. And that's like falling off a cliff. So this IVF is not without its psychological issues, and acupuncture may help in calming us all down.
Thank you, Professor Chapman. Anna here has a question. She says, hello, doctor. I'm doing an ICSI cycle now after a failed IUI. I will be freezing embryo for a week before implantation. As my previous ICSI, I had severe OHSS. What are the chances in falling pregnant from a frozen embryo? Thanks for your help.
Okay, well, first of all, it's very rare with the modern therapies that we use to get OHSS. I know it still happens, but it happens in clinics where they're still using the old-fashioned regimes. So your odds of getting hyperstimulation if the right combination of drugs is used is extremely low, like 1 in 1,000. But that said, if the regime is the same and you get lots of embryos as a result of that and they get frozen, provided the laboratory that is attached to the clinic is a very good one, frozen embryos have the same chance of success as fresh embryos. And indeed, some clinics around Australia and internationally are freezing all the embryos because some doctors think it might be better than fresh transfer. So provided they have a good freezing program and provided that that's done appropriately, it doesn't totally avoid the chance of hyperstimulation syndrome if they don't use the right drugs, but it certainly reduces it.
Another question, would a certain diet help sperm count?
Diet and sperm counts, okay. Well, I'm afraid it's the same answer as I gave earlier about egg quality. No one knows any scientific evidence to suggest that any particular diet is better than others in terms of sperm quality. There's one area of sperm quality that diets may impact on. I say may. There's something called DNA fragmentation, so that all the genetic material of a sperm sits in the head of the sperm, that tadpole-shaped thing. In the head of the tadpole, all the genetic material. And in some men, and we don't understand why it happens in some men than others, it increases with age. We know that age is an issue. We know that cigarette smoking is an issue. We know that alcohol is an issue in this breakdown of the chromosome material called DNA fragmentation. So having diets with antioxidants present in them seems to work. And there are medications like vitamin C, as simple as that. Menavit is the drug that the pharmaceutical industry is flogging, but taking vitamin C and vitamin E is much cheaper and is just as good. They say red wine has good amounts of antioxidant, but then that may not do so good if you drink too much of it. But in terms of overall diet, no one's got any evidence that diet makes a difference.
Rebecca has a question for you. We had a full fresh IVF cycle last month and only had 2 times day 5 blastocyst successful. We unfortunately had a miscarriage at 5 weeks. Will this happen again, likely with our other embryo, as they were collected in the same cycle?
I would have liked to know your age before I make a comment. So 2 blastocysts is actually pretty average for any woman over, well, really over 30. 2 blastocysts would be the normal outcome. You mentioned the word only, but in fact, that would be our expectation. So miscarriage generally relates to the genetic makeup of the embryo. And we know that IVF doesn't improve or make worse the chances of those genetic abnormalities in the embryo. It's the same as if natural conception. So any pregnancy that you set out on, probably if you're 30, 1 in 6 transfers where you've got a positive pregnancy test will end in a miscarriage. By 35, it's 1 in 5. By 40, it's 1 in 4 of the embryos will be genetically will miscarry because of genetic abnormalities. Nature probably removes a number of other embryos before they get to day 5 because they are genetically abnormal. We know, and that all relates back to the chromosome makeup of the egg. And we know that as women get older, that egg quality I was talking about actually is about chromosome anomalies in the egg. They increase with age. So if you were 30, I would say the chances of a miscarriage next time if you got pregnant with that embryo would be no different. Still would be 1 in 6. If you were 40, because of the background numbers I was talking about, it's probably down to 1 in 4 chance. But certainly it's because you have miscarriage in 1, it certainly doesn't mean you're going to get a miscarriage the next time. Hope that answers the question.
Nick is asking, which is better, a day 5 blastocyst stage or a day 3 cleavage stage?
Okay. Well, day 5 embryos definitely per embryo do at least 50% better in terms of a pregnancy. So that's why 85% of clinics in Australia do day 5s. We used to do day 2s and 3s, and then we freeze a lot more embryos, but they individually have a lower chance of success. So you can go through more frozen cycles to use those embryos up. And at the end of the day, if you had, let's say, 5 day 2 embryos, and if you grew them on, you only got 2 blastocysts. Once all of those 5 cycles have been done, or the 2 blastocyst cycles have been done, the results are pretty similar. It's just going to take you much longer and much more expensive to get to the right answer, because we believe that growing them onto 5 days basically culls the not so good embryos.
I have another question here about Diabex. I've been given Diabex. She reckons I grow too many eggs, hence the quality of eggs may not be good enough. Is this the right medication?
It sounds like you've got polycystic ovaries, That's where I would use Diabex. In terms of proving that it makes any difference to quality, I think it's debatable. There have been studies suggesting it might, and there have been studies suggesting it's had no effect. Generally, I'd reserve Diabex for women who have insulin or tendency towards diabetes shown. I wouldn't use it generally. And I personally don't believe that having too many eggs is a problem. What we know is that if you get 10 eggs, we expect about 7 of them to be mature, 7 or 8 of them. If you get 20, but you've got 7 or 8 eggs. If you have 25 eggs, only about 50% will be mature. So that's 12, but that's 12 is still better than 7. So, I don't think it's a problem. Percentage-wise, it sounds like a problem in that you've got a higher percentage of immature or eggs, but in terms of the numbers of good eggs, you still end up with more.
So while in the process of an IVF cycle, would one have to stay away from certain cleaning products or chemicals?
Sorry, I missed that. You better speak up a little bit louder, please.
While in the process of an IVF cycle, would one have to stay away from certain cleaning products or chemicals?
I suppose, in the early days of pregnancy, it probably is an issue. It potentially has an issue, but you'd have to be exposed to quite toxic fumes to have any real impact. So, basic cleaning materials, I don't think have any big effect.
Bonnie says, hi, Professor Chapman. With a family history of fraternal twins, am I more likely to have OHSS? Age 25, fit and healthy. If yes, is the risk still very low? Thank you for your time.
I don't think the maternal history of twins has any impact on your chances of getting OHSS. What will have an impact on OHSS is getting the correct dose for your AMH level, that's the number of eggs that you've got, and your hormone profile, which if it's towards polycystic ovarian syndrome, you do have a slightly higher chance. But as I said earlier, with modern treatments using a particular trigger injection, the one that matures the eggs just before we collect them, if you use the correct one of those, you will not get OHSS. So don't be worried about OHSS if you're going to a clinic that is using antagonists. It's called a GnRH antagonist and a GnRH agonist trigger. But to ask your doctor whether they're doing the modern treatment.
We have another question around male sperm. Does Clomid for a male help with sperm? Usually a female would be prescribed this for medication for ovulation, but doctors seem to be prescribing this for males.
Okay, when there's poor sperm quality, usually it's because the production line is faulty, not because the hormones coming from the brain are doing the wrong thing. So for instance, in polycystic ovary, the reason there's a problem is that the hormones from the brain, from the pituitary gland, are imbalanced. And therefore we can correct that with medication. In the male, when the production line is not working, usually what happens is that the pituitary gland tries harder to produce more sperm, and so the hormone levels are already elevated, and so giving more is not going to make a difference. There are small numbers of cases where the pituitary gland is switched off, and therefore by giving medication we can improve the situation. I see that in young burly men who go to gyms and who take steroids to make themselves look pretty buff. And whatever the guys at the gym say, that it doesn't affect your fertility, they're wrong. I see many men with low sperm counts because of the steroids. Fortunately, over a period of time, and now we're talking 3 to 6 months to 12 months, it can recover, provided the guy accepts that he's not going to have quite the buff muscles that he had before. But that's a relatively small number of cases. In the majority of cases, medication for men is not going to work.
Another question here, what supplements can assist egg quality? For example, CQ10.
I think I've answered that question already. Nothing that we know of. I wish we could. If I could discover something that improved egg quality, I would be a billionaire tomorrow, because just as it's happened tonight, woman after woman is asking the same question. Can't we improve my egg quality? And the answer is sadly, no. I mean, various people have suggested things. So, and I have to confess, I do use some medications. I recommend using CoQ10, which is a vitamin. Why do I do that? Because in mice, a group in Canada showed improvement in older mice of having better eggs. But mice are not men. And the dosage that you have to take would be so substantial as to be toxic. So if we were going to mimic the mice model, but I don't think it does any, well, I'm sure it doesn't do any harm, and it may do some good. So CoQ10. There's some evidence that giving androgens, male hormones, to women in low doses may improve egg quality. There's an American group who really totally believe in it, but randomized controlled trials have yet to prove it is significantly improving. But again, at low dosages, 6 or 8 weeks of male hormone in low dosages does you no harm, and it may do some good. So they're the only two things that I use.
Peter has a question here. He says, hi, we had 8 eggs collected. We lost 2 and implanted 1. We had a boy. He's about to turn 1 next month. We are thinking of having more. I would like to know if we implant 2 eggs at the one time, will that have a better chance?
Well, that's what we used to do to improve the success rates of IVF. And as our technology improved, we got more and more and more twins. So in America, for instance, where double embryo transfer to up to about 5 years ago was about 90% of cycles, they were getting up to 50% incidence of twins. The problem is, as I mentioned earlier, twins are not good. You double the chance of having a baby die, and you 4 times the risk of cerebral palsy in twin pregnancies, because twin pregnancies can deliver early, and that prematurity has an impact. Children spending a lot more time in neonatal intensive cares. So in Australia, 90% of cycles now are single embryo transfer. We actually lead the world in terms of that safety move to ensure that when the baby is born, it is of the best quality. Having 1 embryo transferred and freezing the second gives you exactly the same chance of a pregnancy in the long term, except it takes you 2 months and it avoids twin pregnancy. Well, virtually. You still can have an embryo divide in about 1% of cases. But generally, we try and avoid double embryo transfer.
Last question here so far. What are the chances of a successful IVF cycle if you are overweight?
Well, it depends on your age. It still comes back to age. What impact in a percentage way? So let me just take an example. So if you were 35 and you're coming to see me at IVF Australia, and you were going through your first IVF cycle, I would say that generally a normal weighted woman would have a 35 to 40% chance of a pregnancy. If you were over 100 kilos, it probably drops back to 25 to 30%. So there's a decrease, but it doesn't stop you getting pregnant. We see lots of ladies who are overweight carry pregnancies without any trouble at all. So it has an impact, and therefore, advising weight loss, easy for me to say, but we do that. We do advise you, and we might put off the cycle for a couple of months to give you a chance, because even a 5 or 10% drop in your weight does improve the chances of success. So Kelly, you got any more questions for me?
I don't think so, Michael.
Okay. Well, all of those that are listening, if you want to ask more questions, feel free. I have an email, m.chapman@ivf.com.au. You can find it on the IVF Australia website. Or if you want more information, as I showed you earlier, I do a weekly podcast, The IVF Journey, where I cover many of these topics in perhaps more detail than I have tonight. So feel free to log on. I'll join the 3,000 others a month around the world that are looking at my podcast. So thank you for being here. Thank you, Kelly, for being the moderator. And I would be more than happy to see any of you who want to follow up with any of the questions that you have or seek my advice in relation to your treatment. I work out of Cogra in Sydney, but I'm happy to do podcasts, Zoom consults or telephone consults if you live outside of the local area. So thank you very much, and hopefully we see you again. In fact, you are going to see me again because next week I'm going to talk about the babies that we create with IVF. So on our next live podcast, I will be talking to you again, so you'll be bored with seeing me. Okay, bye-bye.